figured this out and what some of your references are. Obviously, I'm sure some of you use the guidelines, that's fine. But I'm looking for, in addition to that, primary literature that really kind of explains why you made the decision you made. All right, so Team 7, take it away.
Hi, we're Team 7. Let me just share my screen real quick. Can you guys see my screen? Okay. So we chose abiraterone with prednisone. And first we did use the guidelines, but then we found a paper that it was called the Stampede trial, and it did like a multi-arm randomized control trial. And okay. Oh, so we did find that it did include like M0, N0, and also M1. But the only limitation that we found was that there wasn't enough significant evidence for very high risk N0 or M0, but it did show that it was better for M1. So that's kind of like the best that we could find.
Awesome. No, that's great. And again, it looks like you did all the right things in terms of looking to see what evidence you could get. You got the Stampede trial really is a sentinel trial for abiraterone. So that's awesome. Other teams, what other options did you come up with? So I'm assuming that, we have 13 teams, and then we also have the P4 Team A. So did you guys come up with anything other than abiraterone? Thank you, by the way. That was great. I doubt you all picked the Stampede trial. I mean, if you did, then you're all reading each other's minds. So that means we're kind of have a hive mind and we can just stop doing oncology because you can just read my mind. Okay. So other teams, other than Team 7, who got something different than abiraterone?
My team's Team 2, and we went with flutamide, 250 milligrams POTID with grosirelin.
Okay.
0.6 milligrams implant followed by 28 days. And we went with a PubMed article, those guidelines for androgen deprivation therapy.
Perfect. And Kate, are you able to share your screen with us so we can
I'm struggling with that. I'm sorry.
That's okay. Oh, no, that's okay. That's okay. If someone else in her team can help her out, that would be awesome. And if not, that's okay too. You can just kind of walk us through kind of what literature source you used. And
so we used a PubMed article, and it says androgen deprivation therapy in the treatment of advanced prostate cancer. And it showed, sorry, I'm just looking for the...
You're fine. Take your time.
Sorry, I thought we put it in our document, but I can't find the information.
That is totally okay.
If you want to move on to another team, you're more than welcome to, and I'll come back. And
sure. No, that's totally okay. All right. So any other team who got, actually, did any other team pick the combination, that combination? Or did you guys pick another combination? Don't make me call on you. I hate doing that. It gives me such anxiety because then I feel bad. I feel like I could be interrupting someone when they're like, I don't know, talking to their kid or something. So any other group? Yeah.
We chose Degarelix.
Okay.
So basically we did like the loading dose, and then after 28 days you give it again. So we also used a PubMed article, and it basically, I don't know how to share my screen.
So there should be a little green button at the bottom of your screen that says share screen. And it's an arrow.
Can you see that?
Perfect. Yes, that's perfect.
Okay. So basically we found that it has a higher or a faster onset. Oh, I think I completely just lost it. Okay, so it basically just said that it had a faster castration onset compared to other medications in its class. The other thing that we found, it's this article.
Sure, and
my internet's like totally bugging out. The other thing we found that because it doesn't have the tumor flare, you don't have to give the second medication, which like reduces its pill burden, which is really nice. So that's why we went with the Degarelix.
I like it. And then I saw something about monitoring. So what's a little bit different monitoring from Degarelix than from some of these other drugs?
I think this is the one that you have to do the EKG, I believe. Yeah, you have to do it at baseline because it messes with the QTC interval.
And then we also want to do PSA, right? Periodic.
Yeah.
Okay. Because we want to make sure that we're, the levels of PSA are low. Now, do you guys remember what testosterone level you want to achieve as much as possible?
Like for this specific patient, or because I know it's 50, but because this specific patient, he should be between like 0 and 3.5.
Right, for PSA, yeah. For the testosterone, absolutely, we want to try and get him under 50, because we know that if we keep him under 50, then the likelihood that testosterone is going to continue to feed the tumor is going to, basically decrease. Awesome. And then for your paper that you found, did they look at overall survival or progression-free survival or anything like that? And did they look at advanced versus metastatic?
I honestly don't remember.
That's okay.
We looked at so many studies.
Yeah, no, we can figure this out together. So it looks like, who is the population of patients here? Okay. So testosterone, yep. Okay, castrate level.
I can look in like the discussion.
Oh yeah, it says, Because one of the things that we want to do when we look at trials is we want to make sure that our patient essentially fits into the population of patients that, within the study. Okay. This is a really good study. I mean, it's well done. Okay, so it's a phase 3 trial. So that's good, right? We want phase 3 trials as much as we can. Okay, so these patients, looks like.
I think it just was the prostate size reduction.
So high risk, intermediate to high risk with curative intent. Okay, cool. So then when we look at something like that, we can say, all right, that's basically anybody who's not stage 4, right? So so that means that this is absolutely applicable to our patient. Awesome. Nice. Thank you. I appreciate that. And what team were you, so that I don't call you?
12.
Okay. All right. So then the next question, let's move on. So let's do team 4. Can you talk about the recurrence? So how did you guys decide, or rather, what bone modulating agent did you decide to pick and why? And tell us a little bit about it and how you found that answer. Team 4. I'm not frozen, right? Because I can see you guys all moving, so.
Hello, sorry.
No, you're okay. Thank you, Poonam, I appreciate it.
Sorry, I was just looking at some
Yeah, no,
other
it's okay.
data.
And there's always a satellite delay, so don't worry. I don't get annoyed. I'm just like, do. I'll wait here as long as I need to.
For recurrence, we put denosumab 120 mg sub-Q once every 4 weeks.
Okay.
We found this article. Sorry. So can you please share the screen?
Yeah. Do you know how? So if you press the little green button at the bottom of the Zoom for share screen, and then you're able to choose what. Yeah, take your sec. Take your time. Thank you guys all, by the way, for being patient with me and each other with some of the hijinks that we have with technology. I appreciate it.
My Zoom is on my iPad, so I'm asking my team member to share it. I texted him.
Yeah. No problem. This is acceptable to phone a friend, so no problem.
If someone will see the message.
Yeah, and it's really nice to have all of you walk through kind of individually again how you arrived at your answer, because as you can see already from the first question, we had a couple of different options that people chose. There were literally 3 different options that people chose, and all of them were acceptable. So, that's one of the reasons why I want you to go through this process of figuring out, okay, well, why does this make sense? And what's the evidence behind it? Because you will get asked that question.
Okay. Let me see. I can just.
And if that doesn't work, we can ask. Oh, here we go.
Yeah,
all right.
It worked.
Thank you.
Okay, thank you so much.
Yeah. All right.
You can click the link.
Mm-hmm. Perfect. Great. Okay, so you chose the denosumab. Now, when you within the study that you found for denosumab, was it compared against another bone modulating agent, or?
Let me see.
Mm-hmm.
They compared it with placebo, sub-Q denosumab 120 with a placebo every 4 weeks.
Okay. So one of the other things I would suggest in this, this is really good. Do you guys think that since we have other bone modulating agents available, that it's reasonable for them to compare it to a placebo?
Yeah, they should compare it with zoledronic acid maybe.
Exactly. So
okay, find that study.
Yeah. So maybe what we'll do is we'll move on to another group while you look up to see if you can find any trials. Okay. So let's see. We did team 4, team 7. How about team number 3? Sorry, I'm brain dead. So team number 3. Well, she's trying to find that. What did you choose?
We chose the same thing.
Awesome.
But we have a different trial I can show you.
Oh, yeah, that'd be great. Thank you. See, PubMed is dangerous. You can basically find any kind of reference to support your decision, right?
Are you able to see it?
Yes. Perfect.
So this is what we chose to look at.
So this actually looks like the same study, right?
Is it?
It looks like the same study. So I see another one.
Yes, it is the same study.
Yeah. So
my bad.
No, it's okay. Keep it up. Keep it up. On the right side where you see similar articles in PubMed, I see a denosumab versus zoledronic acid for treatment of bone metastasis. So this may be an interesting study. So when I'm looking through and trying to figure out really quickly, like, if I need to make a decision about a patient, we can see, do you see if the overall survival or anything else was higher? Interesting. Interesting. Okay. So it was further assessed for superiority as a secondary endpoint, but this wasn't necessarily a head-to-head. Interesting. Okay. So that one really doesn't necessarily, it doesn't necessarily say that it's that much better, right? So if you look at this trial, now this was done in 2011, so I'm assuming there are probably many more trials post this. But originally what they're looking at is they're not looking at overall survival, right? They're not looking at quality of life either. All they're doing is looking at time to a pathologic fracture or radiation therapy or spinal cord compression. So they're literally looking at, compared to denosumab versus Zometa, which patient population ends up having a bony event sooner. And they're saying that the time to bony event was a little bit longer for denosumab, but it was only like 3 months, right? Not even. So, all right, well, let's see if we can find a study from a little bit more recently. Does anyone else have, did anyone else have a different answer or a different study that you used? Nope, you guys all picked denosumab. Yeah, because it was a category 1 recommendation in the guidelines, right? So for those of you who went to the guidelines, you're probably like, oh, this is perfect. It's a category 1 recommendation. It's a category 1 recommendation for a few reasons. One of them is it's really easy to give, and the incidence of osteonecrosis of the jaw is probably a little bit lower than some of the other bone modulating agents like pamidronate, zoledronic acid. Based on the quality of life data in breast cancer, we know that denosumab is a little bit easier for patients and may work better for them. And so a lot of extrapolations were made to prostate cancer patients. And the decision was, well, if the quality of life data is better in breast cancer, it's probably similar in prostate cancer, since they're both very much hormone-driven cancers. Awesome. Okay, thank you. Now we have one last question. Do we have any volunteers for what you guys chose after he progressed the last time? And there are plenty of options that we could use. So is there a team who'd like to volunteer? Maybe I can ask, actually, you know what? I'll ask team A, I'll ask the P4s. So what'd you guys come up with? I'll give the P3s a break. How about that? Show us what you know. Plus, they had like 20 people in their team. So, no, I'm kidding. It's about 11, but. Team A, did you all disappear? Jackie.
Hi, Dr. Leyva.
We got feedback. That's all right. Anybody else from Team A? Since Jackie's Zoom appears to be going crazy.
Can you hear me? Sorry. This is Leah.
Yes, I can hear you.
Okay, great. What question was this for? Was it for the bone modulating agent?
No, the last one. So patient had docetaxel and prednisone, and it looks like he got worse. So what?
Okay. Mm-hmm. We actually were kind of We were a little bit stuck, so we actually didn't really get to that question at this, for this session. Sorry.
Totally fair. No problem. All right. So what other P3 group would like to help out your P4 colleagues?
So team 2, we went with cabazitaxel IV 20 milligrams once every 3 weeks plus prednisone.
Okay.
Pre-medicate for at least 30 minutes prior with each dose of with antihistamine or corticosteroid, and then monitor CBCs with LFTs and serum creatinine.
Mm-hmm. Awesome. And what literature did you find to help support that?
I am opening that up.
Okay, great. Sorry.
Again, it's a PubMed article, and it talks about treatment of metastatic castration-resistant prostate cancer. Mm-hmm. And then the results indicated that. Give me 1 second. Sorry.
Yeah, no problem.
It's kind of brief, but it basically talks about the cabazitaxel can be applied secondary to docetaxel, and it helps to decrease the PSA. A short PSA, it basically doubles the time, and without metastasis in conventional imaging. So I think that we're just looking at imaging and the recurrence after giving that.
And did it also talk about overall survival? Was that like a primary or secondary endpoint?
Yes, it says that compared to the darolutamide and enzalutamide, significant prolonged metastasis-free survival.
Interesting. So okay. Yeah, and that makes sense, right? Because enzalutamide and some of the other agents for patients who failed androgen deprivation therapy, it would make sense that you would compare cabazitaxel against one of those, right? Versus cabazitaxel against docetaxel. Because they're not equivalent drugs. We give docetaxel first, that's first line, right? And then if they fail that, then cabazitaxel is really an alternate therapy or second line. Awesome. Thank you. Did anybody pick anything else? Did another group pick something other than cabazitaxel? You all picked cabazitaxel.
I'm team 4. We picked Yonsa.
Nice.
Yeah, because that was category 1 with methylprednisolone.
Perfect.
And I looked at the package insert of Yonsa, and we found a study there. The name of the study is STAR trial.
Yep. Perfect. So, the point of this exercise was for you to really learn how to try and find resources, right? And kind of have some guardrails set, which is why I had those questions, because I wanted you to do your searches and also have those questions in mind so that you really were evaluating the quality of your sources. But also, I'm hoping that the biggest lesson you learn from this experience is that there are a lot of options in prostate cancer. I mean, you get to a point where when you get to metastatic prostate cancer, if you have visceral metastases or if you have other problems associated with it, other comorbidities, then we might start narrowing down the things that are available. But that at very least, there are a number of category 1 recommendations. So one of the things that makes this hard with prostate cancer, in breast cancer, we have like one category 1 recommendation, right? Depending on the kind of cancer you have. But in prostate cancer, when you have like 3 or 4 category 1 recommendations, how do you decide? Well, you decide based on your patient. So for example, if I had put in this case, patient refuses injections, all right, then you're going to have to start coming up with something. If your patient, refuses to have blood products, you might not want to choose cabazitaxel because you know that the patient might end up needing transfusions, right? So like there's a thought process that needs to go through all of this. Or for example, if I put that the patient couldn't get access to Xtandi or abiraterone because their insurance didn't cover it and their copay was too expensive. How do you then make a decision to try and maintain a category 1 recommendation so you're not giving somebody a suboptimal therapy, but taking into account what the patient needs? And this is when you need to be able to pull data and say, okay, this is still a category 1 recommendation. I can use it in this patient population, even if it was maybe studied in a slightly different one, but I can extrapolate, and here's, my evidence behind it. So I really hope that this exercise, and we're going to keep doing things like this, helps you feel more comfortable with going through guidelines, going through PubMed. Anytime people start a search in PubMed, it feels daunting. You're like, oh my God, there's so much information. So I'm hopeful that within the next couple of weeks, we'll keep paring down information and you'll start feeling more comfortable with it. So as a class, just kind of getting some feedback from you, do you find that these kinds of activities are useful? Like, are you starting to feel more comfortable with literature searches and things like that? Yes, in general? Okay. I'm really not trying to stress anybody out or put you on the spot. I don't want you to feel like if I don't know the answer, then, I'm not doing this right. It's really okay. And I expect that some of these activities are going to be easier for some people than others. So that's why I want to call on all of you, because I know that you're going to have something to offer. So thank you. All right. I'm going to give you guys back 15 minutes of your life. Woohoo! Before I let you go, is there anything from today or in general that you have questions about? Anything that's unclear? Are you feeling like the cobwebs from EBM are lifting a little bit? So if I give you tables for the next exam, you're not going to panic, right? You're going to look at percentages, make sure that you read the question fully and not freak out. Okay. I see a lot of smiling and laughing. Everyone knows what I'm talking about. Okay. Awesome. All right. Well, then in that case, I already made your IRAT available for tomorrow, and I'll finish putting together the application for tomorrow as well. I think I've added all the materials for this week, and I will be adding next week's materials as quickly as I can. I have one lecture to record, but everything else is done. Cool. All right. Well, happy rest of your Monday, and thank you guys for showing up and for participating.
You were
really awesome. Yeah.
You were supposed to walk us through how to approach a question when we had that internet disruption. So.
Oh yeah. So I can do a more condensed version of it right now. So just give me 1 second. I just wasn't sure if you guys wanted me to go ahead and do that. Okay. Let me pull up. I'm going to share my screen with you. Okay. All right. So if I have a drug question, so first of all, if I know nothing about a disease state, right? So let's say I'm being approached by an oncologist who says, hey, I want you to tell me, I want to know what treatment I should give for X cancer, that I'm like, whoa, that's bizarre. I haven't heard of that. My first stop is usually, if I don't know anything about the disease state, is to go to UpToDate. It's a nice, quick and dirty way of kind of getting a little bit of information about epidemiology, pathology, and then usually they'll give you some treatment information. From there, I try and pick up keywords, right? So let's say, for example, I'm looking up docetaxel in advanced prostate cancer. So I'm going to go to, we could do a couple of things. I could go to Google. The problem with Google is you really have to know the quality of what you're looking for. So if you feel pretty reasonable or pretty comfortable being able to identify what's something that you should click on. So I might start with docetaxel, let's see, landmark. So the terms landmark or pivotal Those 2 words will help you find a drug, for example, that was actually given an indication because of a particular study. So this is one of the easiest ways I can skip ahead of trying to look through and see, like, you know, what study I should pick. So landmark trial for docetaxel in, let's say I don't want metastatic. I want to look at advanced prostate cancer. And then I start seeing, like, okay, NIH.gov, and I look at the year, right? So if I see something from like 2011 or 10, I might try and look to see what is more recent. Understanding that sometimes these landmark trials that got a drug approved might actually come from a number of years ago, and that's fine. So then you can start with the trial that's easiest to access, and then you can go from there. So let's see, I see stampeding. So let's see, what is this? This is an article. This is a mini review. I could do a mini review, but I really want primary literature, right? But if I can't find primary literature right away, I might go to a review and pull this up. And I can always read it, right? Just to get myself a little bit more familiar. And then I can look down at the references and see if I can try and find something specifically that is the landmark trial. And in this case, and this sometimes takes a little bit more time. Let's see, first-line androgen, deprivation therapy. Okay. Here we go. So there we have a number of different options. And again, depending on what I'm trying to find, I can pick one of these. So if I'm not happy with any of these articles, then I can always go back and I can say, okay, well, I'm going to go to PubMed. And now I know that it's a Stampede trial. So I can look up and see if I can find the Stampede trial. And then I can start looking for there, okay, you know, which one was a phase 3? So I see that this one's a randomized control trial. This isn't a review article. So let's say I pick this one. A lot of these landmark trials that get drugs approved are actually available for free because drug companies want providers to see these articles so that they can prescribe the drug. So anyway, this is, again, kind of loosely how I go through and try and find answers to questions. Sometimes it's really easy to go to the guidelines and just look and see what drug, and then go to the references within the guidelines. But in the case of prostate cancer, there's a lot of information. And if I don't have time to like look through every single algorithm, and I already know kind of what drug I'm looking for, this is one easy way of doing it. So you can go to UpToDate, learn some information, figure out what drug, try and find a landmark or pivotal phase 3 trial. But in oncology, are every single drug that are approved, do they all go through phase 3 trials? Do you guys remember?
No, they don't.
They don't. So there are a lot of trials that unfortunately get to phase 2, and then they get what's called an accelerated approval, right? So in that case, if you don't have phase 3 data, assume that the phase 3 data is being gathered, because in order for someone to keep their indication, they have to prove at the end of the phase 3 trial that in fact their drug is efficacious, safe, and has a benefit. But if you're operating with just phase 2 data, you do the same kind of thing, right? You find the trial, you look through to see what was the schedule, the dose, the duration, and then the overall survival. Well, they won't have overall survival, but they'll have progression-free survival. Usually, or they'll have like disease-free interval, something like that. Okay? So there are a lot of different ways you can approach these drug information questions, but the bottom line is, if you're able to figure out what words to put in your keyword search, this is going to get a lot easier for you. And also identifying, the appropriate search engine. So ideally, we want to go for PubMed, but if you're not quite there yet, that's okay. You can kind of use this systematic approach to finally get to PubMed. Does that help clarify a little bit? Does anybody have questions with that? Or anything that didn't make sense? Okay. And Patrick, did that answer your question too?
Yeah, thank you.
Yeah, no problem. And thanks for reminding me. Awesome. Okay. Well, if there aren't any other questions, then I will let you guys go. And if you do have anything that pops up, just send me an email and I will respond. Cool. Thank you again for being patient with the internet stuff. And I will see you guys bright and early tomorrow.
Thank you.
Cool.
Thank
All
you.
right. Ciao. Yes. I hear somebody asking a question. Oh, hey, Jackie. All right, we can't hear you.
Great. My connection's really bad.
That's okay. I can hear you now.
Okay, goodness. Sorry. So
okay.
did you sorry for the roundup. We had really great answers for the first two. We just spent literally 30 minutes just trying to get everybody in the same document and fixing everything. So
it's okay. Don't worry about it.
So for a future ref, I only stayed in for the first couple of minutes of the last week. So this is basically how we're going to be doing the format for these patient care series with you?
Yep, exactly.
Okay.
Yeah.
Is there a way?
Sure.
Go ahead.
No, go ahead.
Oh, I was just going to ask if there was a way to get us like on our own group Zoom. That way when we break off into teams, we already have that established document, like have that established area where we can all work independently.
Yeah, unfortunately, I'll have to put you guys into your breakout rooms. Like I'll have to assign that after I send everybody else into their breakout rooms.